putting our fingers inside the ear to try to get to the posterior aspect of the joint. And at that time, the sensitivity and specificity values only including lateral pole is less or lower than the sensitivity going around the pole. Adding around the pole to the exam increase our ability to identify the true positive. One reason being that now the palpation is 1 kilo around the pole, which is a higher stimulation, or a more intense stimulation to the joint. So I think that allow us to improve our certainty about identifying that is joint pain. And it may sound very simple. Yes, Cindy, if you have a question? Yep.
It's Jenna.
Oh, I'm sorry. I hear Sandu. Can you open your video, please, to talk to us?
Oh, yes.
Yeah.
Okay, can you see me now? Okay.
Yes, we can see. Oh, I'm sorry. Yeah, it was a different one. Jenna, go ahead. Jenna Rose.
So the myofascial pain is the lowest sensitivity and specificity due to the fact that it's the hardest to replicate?
So far, it was the sensitivity was 89. Let me go back for a second to be sure I'm saying the right thing. It was 86, the sensitivity. So the sensitivity is affected by the fact that the phenomena per se is more difficult to identify and the prevalence is lower. Yes, that's the answer to that.
Thank you.
Yeah. Okay. Very good. So here I was trying to say in arthralgia that the sensitivity was 89, specificity 98, and that we were able to ram the the sensitivity by adding around the pole, which is now a more dynamic palpation and is with more force, it's 1 kilo. I know before Jenna asked the question, I was trying to say that in addition to that, even though it may sound very simple, oh, I know where the masseter is, I know where the joint is. One issue to keep in mind is that to identify the lateral pole and around the pole is not as simple as it may show this particular picture here. So we may ask the patient to slightly open, right, and move the jaw forward. So when you do that, you will feel a concavity once you move your jaw forward. And when the patient comes back, that's where your lateral pole is. And during the exam, we may ask the patient at the beginning to do these movements in order for us to identify the location of the lateral pole and obviously to be able to do the palpation around the pole. Monica, you have a question?
Yeah,
Go ahead, Monica.
How often is there arthralgia in one joint versus both joints?
Interesting. I wish I will have a number to give you exactly. I will say that based in my clinical experience, and I will let Dr. Kattouf and Dr. Crow to mention, I seem to see more bilateral joint problems and combine arthralgia with myalgia. In fact, in one of the studies that we did here at UB, called the JGB study for biomechanics, when we were trying to recruit individuals that only will have an arthralgia diagnosis was almost impossible. And then we have to move the classification and the whole methodology to call it pain and being mainly myalgia. So the answer to my question is I don't know the number, which is fine to say I don't know. In my experience, I think it's most common to have it bilateral than unilateral, but I will let my colleagues to help me.
So I'll chime in. I think if you're looking just at arthralgia, no myalgia at all, I find that to be very rare. What I see, I'm probably not as certain as Dr. Gonzalez that I see more bilateral than unilateral, but it you're going to have unilateral painful diagnosis, which would include your myalgia, your arthralgia. You know, if it's going to be unilateral, that's going to be where you're going to get the unilateral arthralgias, when you had unilateral arthralgia and myalgia, which we do see. It's one of the reasons why we specify in arthralgia whether it's the right or the left joint. We don't specify in myalgia whether it's the right side or the left side. And in myalgia, we don't say it's the masseter versus, we just call it myalgia. But in arthralgia, we do specify it, and that's where I get this clinical sense, although I have no idea what the numbers are, that we do see unilateral, not infrequently.
Dr. Katouf, you want to add anything?
No, Doctor, I'm happy with what you say, Dr. Go.
So, Monica, the answer to your question is we don't know, because we don't have a number to give you. We give you our impression and a long explanation for we don't have the number, which is fine too. You have to know what you know and know what you don't know. But that will be interesting when we are doing data analysis for other projects. Maybe that those numbers should pop out from unilaterals and bilaterals. So next year, when somebody else asks the question, we will have the numbers. How that sounds, Monica?
Sounds good.
Sounds good. Okay. So the next group, I said, is probably one of my favorite diagnoses. And that is headache attributed to TMD. And headache attributed to TMD, the first thing I want you to remember is that it's a secondary type of headache. Why is secondary? It's secondary to a painful TMD diagnosis. In other words, you must have a diagnosis either of myalgia, myofascial pain with referral, or arthralgia first in order to have a secondary headache or headache attributed to TMD, which is secondary to the painful TMD diagnosis. And I think that's where people get confused and start giving me in the examinations, in your exams, in your tests, this diagnosis without checking and confirming that you have a myalgia, myofascial referral, or arthralgia. By history, your patients are going to tell you that they have a history of headaches, any type of headaches in the temple region. And somebody asked that question last week, and that headache is modified by jaw function and parafunction. And then during your clinical exams, again, you are going to be confirming that headache either during range of motion or palpation. And I have here this big red arrow too, so you don't forget that you must have a primary diagnosis of pain-related TMD to be able to provide a headache attributed to TMD. So
can I break in too, just for a
yes.
moment? I
Yes,
want
yes.
folks to remember that primary and secondary medical diagnoses occur in lots of diseases. So a primary headache is one that is the primary problem. Nothing else is causing it. A secondary headache is caused by something else. So it's easier to remember, I think, if you put it in terms of other conditions. You can have primary hypertension, you can have hypertension as a result of renal disease. That's going to be secondary. So put it in that context. It's being caused by something else. It makes it a secondary diagnosis. Thank you.
Thank you. I love actually that example of the hypertension. Very good. So you have to have one of the TMD as primary that are causing the secondary headache. I like that. So by the history, again, your patient is going to identify that in the last 30 days, they have headaches that include the temporal region, okay, or the temple, right? And that temporal headache is modified, again, by function and parafunction. And notice that are exactly the same questions that we ask for pain. And in the past, a lot of people ask me, can patients differentiate between pain and headache? And the answer is yes. And by the way, all these forms, reliability was done among the participants of the study to see how reliable the forms could gather, or how reliable were patients providing the information. So yeah, they can differentiate. A patient will tell you, no, that is my migraine headache. No, today I have my hangover headache. No, that is my pain here. They can, discriminate, because they don't only have to have one headache. They may have many types of headaches, even if they are primary. Okay, so from the clinical exam, you can replicate that during any range of motion, meaning maximum assisted, unassisted, right, left, lateral, or protrusion. And the question is, if the patient said, you measured the unassisted, was that movement painful? Did you experience pain with that movement? That's the question. And they say, yes, show me where, and they go here and here. So you confirm here and here, yes, so bilateral temporalis. So I start with my right one. Was that pain familiar? Yes. Was that familiar to your headache? Yes. And that's what this yes is coming. Or during the palpation of the temporalis, in which you will ask, I'm looking for the form, give me 1 second, or in the palpation of the temporalis, in which, after applying the 5 seconds and in my posterior band, I will ask, is this painful? I'm your patient, yes. Is that pain familiar? Yes. Was that pain familiar to your headache? Yes. Was the pain only under my finger? No. Can you show me where you experience that pain? On my eye. So I will mark it yes as a referral. Okay. That makes sense? I hope. So again, during palpation of your temporalis. And this is my friend Kim. She used to have horrible headaches, and happened to be that they were headache related to TMD. She was the first social worker we have in the CARES program. She was fantastic. She's now the person who runs social work at Buffalo State. Excellent individual to collaborate with. And here is a summary of how certain I am. So I feel with myalgia, I am very certain 90 and 99%. Myofascial pain with referral, 86 and 98. Arthralgia, 89 and 98. And headache attributed to TMD, 89 and 87. Anything that is above 85% is considered excellent validity for both. And I call it clinical validity, how you assess clinical validity by measuring sensitivity and specificity, which means the ability of you to identify your true positive and the ability for you to identify your true negative. So I feel very confident when I'm providing this diagnosis. Any questions so far? No questions. So let's do a case. Oops. So the case is a 56-year-old female came to our clinic with the following chief complaints. I have pain in the side of my face, pointing to the right masseter, temporalis, and preauricular region. Her pain is present upon awakening. And we will, Dr. Kattouf talked about the pattern of the pain last week, and is described as dull. She talked about last week again about how the pain is described, or nature of the pain, dull and aching. Alleviating and aggravating factors are chewing and talking, so function modifies the pain. No associated factors present, meaning this patient doesn't have phonophobia, photophobia, vomiting, fever, or anything else. Patient described that the symptoms has been present for at least 6 months. There is no history of trauma and no relevant medical history. Patient denies history of headaches. used to read, so now I have to read and it's far. So if the patient denies history of headaches, you already know that you cannot and you most likely will not be able to have which diagnosis. Jacqueline Kim, which diagnosis you cannot have if the patient is denying presence of headaches.
It's fine.
Jacqueline,
I have a question.
Hello?
Hello, yeah. You can
Oh,
open
sorry.
your video
Hi.
so we can see you.
Okay.
Hi.
Sorry, could you repeat the question?
So if a patient denies a history of headache, which of the four diagnoses that we already discussed cannot be allocated to this patient?
I'm not really sure.
That's okay. I take that as an answer.
Okay.
Do you want to call somebody? You want to call a friend?
Sure. Monica?
Monica.
Hi.
Monica, you are the star today.
Here it is. It would be headaches attributed to TMD.
Absolutely, because you don't have that element in history. Very good. That's like a good question for the exam, Dr. Crow. So here is your symptom questionnaire for today. Yes, pain that comes and goes. Oops. And is modified by chewing and other activities. And the patient denying history of headaches, and if they have no history of headache, obviously cannot be modified. Upon clinical examination, the patients identify the pain being identified, and the examiner confirms the pain being in the temporalis, masseter, and TMJ in the right side. No headaches, over yet 3 millimeters, no midline deviation, and she have an opening corrected pattern. Vertical range of motion is 15 millimeters pain-free opening. Maximum unassisted is 37 with no pain. Maximum assisted is 43 with no pain. Right lateral is 8 with no pain. Left lateral is 7 with pain that is familiar in the right TMJ. And protrusion is 4 with no pain. And now joint sounds are negative and locking history is negative. We will be addressing this in the next group of diagnosis. That's what I put in negative. And during palpation, we have pain in the temporalis, which is familiar, not familiar to headache, obviously because she doesn't have headache, so it cannot be familiar, and is no refer. In the masseter, which is familiar, no refer. Nothing in the left side, nothing in the TMJs, and nothing in the supplemental muscles. And I know you can read the next slide, okay? But I guess the summary here is pain that is modified by function and parafunction is confirmed in the joint and in the masticatory muscles. We have familiar pain upon palpation in the masticatory muscle, familiar pain in the right TMJ during range of motion. Therefore, the two diagnoses that can be allocated are myalgia, which is, as Dr. Crow, you don't have to say if it's right, left, and which muscle, but you have to be specific when you do the arthralgia diagnosis that is in the right joint. Because in your examination, you will have to specify if it's right, left, or bilateral. And you will not receive partial credit if you don't identify which joint. Okay. And then the next page. This is the last part of your examination form where you can as well mark myalgia, prior arthralgia, and we haven't discussed intra-articular disorders. That's why this particular case says none. So this is probably one of the simplest cases that you can have and something very similar probably will be in your examination. Any questions so far?
Hi, Dr. Gonzalez. I had a question.
Yes, who is talking? Scott.
Hi, this is Morgan. How are you?
Hi.
I had a question. If we took a step back, I remember on the initial taken slide, she had like auricular pain or preauricular pain. What if like we were considering a differential diagnosis? How are we not like how are we canceling out the idea of there being an ear issue?
Oh, very good question. So you are right. She says preauricular area, right? So you are doing your history, and I'm giving you a very summarized history that will allow you to get to the diagnosis. In addition to the summarized history, I'm giving you the symptom questionnaire, and I'm giving you as well that as an examiner, I was able. I'm sorry. I'm able to identify the localization of what she called preauricular in the TMJ. But you are absolutely correct. Before I even get to my questions of my symptom questionnaire and going into my exam, I spend 45 minutes with my patient taking medical history, medical history, medication, and history of the chief complaint. And I probably ask her a very key question for me to rule out that is not in the ear. Which questions do you think I will be asking my patient to rule out that is not in the ear? I will ask her, does your pain get better or worse when you lay down, right? And if the patient lays down and they feel more pain, it's probably because it increases the pain in the ear, and most likely it's going to be on otalgia, otitis media. I always like to give the example of babies. For those of you who have babies, you may notice that when a baby cries at night, because have pain in the ear, you will put it in the crib, and 3 seconds later, it's crying again. And the reason why it's crying is not because the baby loves you or want to be with you. The only reason why the baby cries is because it increases the pressure in the tube, and that's what again triggers her pain. Is you have a otitis media as well. Another question you could ask is, have you been in an airplane recently flying, which these days is almost impossible. But if you have otitis media, you will feel a very extreme pain as the pressure in the cabin changes, versus a preauricular pain that feels better when I lay down and rest and I relax my jaw. Now most likely it's going to be joint related. 2 classes from now, when we start doing other orofacial pain conditions, otitis media is one of them, Morgan, and then you can help me to talk about otitis media. But I agree with you. I'm giving you and you have to get used to interpret as well the information that is given to provide the diagnosis with the information that is given there. So if I didn't say that the pain, or maybe we want to be super clear that the pain is not modified by any head position or something like that for examination purposes. But if I ask to you based on the DCTMD, well, you know that you need those 2 questions from the symptom questionnaire plus your clinical examination, right? Versus if I ask you based in the narrative, which other conditions you may, so I will have to give you more info. Does it help? I believe Dr. Crow wants to add something more.
So one of the things is Dr. Gonzalez gave you a case that because you replicated the pain through the motion, you have your arthralgia diagnosis. That doesn't mean they could also have an otalgia, but you have your diagnosis because you met that criteria. So we have many patients that have more than one thing going on. And sometimes when I'm not sure what the primary issue is, we'll treat the known diagnosis, in this case, the right arthralgia. And if the ear pain persists, then we need secondary referral. We need to send them to ENT. But often in those cases where you're not quite sure, you treat the diagnosis you're sure of and the pain resolves, then you're fine. You don't need to refer to ENT. So that's kind of one way to parse it out too when you're dealing with a patient.
Got it. Thank you.
I want to add to that, Morgan, that in addition, and when we talk about otalgia, you will see, the patient probably will be complaining of position of the head. In addition to that, maybe some secretions coming out of the ear. So imagine I have a patient coming, say I have pain here. They told me maybe it's TMJ, and I'm looking at the patient and observing, and I see this goop, kind of yellowish, greenish coming out of the ear. I will not ask the patient to open as much as they can. I mean, I will immediately stop and refer the patient to ENT, right? Or they may get loss of audition in that side, fever, so on so. But I like your comment in the sense that in addition to these criteria, you are thinking there may be other things, and it may be other things. But for examination purposes, if we ask you about the DCTMD diagnosis, you know that you have to use these history elements plus the replication of the pain during clinical examination. I believe Sandu have a question. Yes, go for it.
Yes, I do have. Hi, Dr. Gonzalez. I have a question in regard to this diagnosis. I was just wondering that do we get any imaging diagnostic for such patients? Like any EMG or ultrasound or any X-ray, just to confirm a diagnosis, or we are just based upon all these instruments and questionnaires you taught us today?
So again, the DCTMD diagnosis for the most common conditions are based in these algorithms that involve the clinical history, and the clinical exam. In addition to that, and we will have, I believe it's actually next week, your imaging lecture, in which, just to tell you, arthralgia usually doesn't correlate with clinical findings. So doing the imaging, and we will discuss imaging this week, so I don't want to elaborate much, but for the diagnosis of arthralgia, you do not need imaging as specified by the DC. Yeah.
Thank you.
Yeah, but keep tuned. Next week we will talk about imaging, okay? Excellent questions. I'm trying to find my mouse. Here it is. So we talk about the most common. That's what the DCTMD allows you to determine. On the other hand, there are other conditions that are muscular conditions that are not part of the DCTMD, and the reason why we're not validated is because they are not the most common. And second, they are not validated. To my knowledge, until 2021, I run it last night. I haven't seen any other study validating other conditions. But if you go to your book, and don't forget you have to read the book. We are right now in chapter 8, the diagnosis part. There are other conditions that are mentioned that we have to be aware, and not just because we don't have sensitivity and specificity, we are going to ignore it or pretend they don't exist, right? It's hard to do studies, to do clinical validation. Among them, as you can see here in this table, you have tendonitis, which implies pain on the tendon with an inflammatory component, myositis, which implies an inflammatory process in the muscle, muscle spasm, muscle contracture, hypertrophy, and neoplasm. We will not make any comment in the neoplasm. You see that with Dr. Tapia in your soft tissue lectures. And then here you may have movement disorders as well that we will be covering in another lecture as well. But let's talk about those few ones that I mentioned. And by the way, fibromyalgia will be when we talk about when we refer to comorbid conditions. But let's talk about the first one here. I'm having issues with the mouse. Okay, muscle spasm. You hear this a lot. Something is happening in my PowerPoint that the slides change by themselves. They don't wanna have me control over them. But anyway, so muscle spasm is something that you hear a lot. Oh, I have a spasm. Oh, a spasm. But what that means? Well, a spasm means that it is a sudden, involuntary, reversible tonic contraction of the muscle, right? And the criteria as presented by the American Academy of Orofacial Pain is that they have an immediate onset of muscle pain, which is modified by function and parafunction, and there is an immediate report in the limited of range of motion. Those patients cannot open as wide as they used to. And in addition to that, at least two of these three ABCs should be present. Pain in the myalgia, that includes the masticatory muscles, limited range of motion, and the movement of the muscle affected is going to be impaired or limited. And the reference standard or the gold standard for muscle spasm is EMG. So these have to be actually with your questions. You mentioned EMG, you said imaging, but EMG as well. So, and there are two types of EMG that you could do. You could do surface electrodes, which sometimes they are questionable, and probably better than surface electrode is needle electrode, putting a needle to the muscle and confirming that in fact there is an involuntary contraction and you see that activity there. We, in that validation process, actually, I remember there was only one patient that we thought it could be a muscle spasm, and it was not a muscle spasm. Do we routinely do EMG in our patients to rule in or rule out that it's muscle spasm? No, we don't. I don't think too many patients would be happy if we would be putting needles in their masseters, besides the fact that we confirm the presence of myalgia or myofascial pain with referral. But when somebody is talking to you about muscle spasm, that's what it means. It means an involuntary, reversible, sudden contraction that limits the range of motion. And if you will do EMG, which is the reference standard, you will see this muscle activity. Contracture, muscle contracture, that's another one that we hear a lot. Means that it's a shortening of the muscle in this case, and is due to fibrosis or due to a scar tissue in that muscle or ligaments, and therefore, because it's a scar tissue, you are going to see a consequential limited on the range of motion. So here I really don't see many. Maybe Dr. Crow have more experience, because this can happen definitely after radiation therapy, and I know she have a lot of experience working at Roswell and other cancer centers, so I will let her make a comment here if she would like to.
Well, it's the problem with contracture is there isn't really a treatment for it, okay? And when you think about that, it's that due to fibrosis, and so that you no longer have that smooth ability to stretch. It's a scar. It won't move. So the goal is to, if you're suspecting contracture is occurring because of this progressive loss of range of motion, the goal is to try and stop the progression, because you won't be able to get it back if it's a true contracture with fibrosis. You can stop the progression generally with exercise, physical therapy, but the patients have to be very compliant with it.
Thank you. The next diagnosis I want you to be aware about it is myositis, which by definition, the itis means that it's an inflammatory process going on in the muscles. So, if the patient have a history of trauma, if I punch one of you in the face today and you come tomorrow with pain, I cannot say you have myalgia. I will have to say you have myositis, right? Because it's a history of trauma associated with that. It's really not that common to see that in our clinic. I assume if somebody has some trauma, probably most likely will go to an emergency room or an urgent care facility. These patients may have a limited range of motion due to the pain and due to the inflammation that is going on. In the past or in areas of the world when there is no access to antibiotic, could be secondary to an odontogenic infection. I used to see those many years ago. And important to remember that it have to do with direct trauma, although has been associated as well with chronic autoimmune diseases that may have secondary to that, may have the muscle inflammation. And the first one that comes to my mind is RA, in which you can have a secondary myositis due to that. I'm telling you, this computer is not helping. For confirming the diagnosis of the condition, it could be done some kind of a test, serological test, but serological tests that are done for inflammation are not specific if it's to the muscle or not. They are more general and they are used for multiple conditions. Hypertrophy of the muscle. I know this is a picture from the internet. Obviously, you recognize the individual here, and you can see a very well demarcated masseter. I don't see the other side to say that he have a unilateral hypertrophy, but definitely he was clenching when they took that picture, right? Definitely clenching. So hypertrophy is described as an enlargement of the muscle, and sometimes patients will come with a series of pictures to show you how this spine of my face is getting bigger than the other side, or how through the time it could be bilateral, it's getting bigger. I don't see it much. What about you, Dr. Crow? Do you have more experience with hypertrophy of the masseters?
No, I don't. Although it was discussed as a aesthetic issue in other parts of the world, and Botox has been used to try and reduce the aesthetics if it is not pleasing to the person.
That's true. And in fact, you just made me think about that study from Botox. And I say Botox because that was the one that was used among the many botulinum toxin aids that are available clinically, commercially, I'm sorry, but it was done for aesthetic. It's a clinical trial going on for the causing atrophy of the muscle to reduce the square type of face for aesthetic reasons. And recently, a paper came out from the Raphael group mentioning that even in the temporalis, when Botox is used for the preventive treatment of chronic migraines, that patients refer to atrophy of the temporalis region, which I think you have to be, I don't know how observant to notice that your temporalis doesn't look as big as it used to look, but it has been reported. But yeah, the treatment is causing atrophy of the muscle with botulinum toxin. So now your patients, and so those are the conditions that you